Your thing is loaded. Be ready to take off. Good evening, friends. It's indeed a great pleasure to connect again today. This will be the last of the sessions with the Beat workshop, and we have received quite a few ECGs from the different delegates, especially Dr. Praveen has been kind enough to send a couple of ECGs, and we'll discuss the ECGs that were sent by the delegates first, and then there were a lot of requests to discuss about the evaluation of a paced ECG. So I have just asked my colleague Dr. Vikram to put together a workflow so that when you have a patient with a pacemaker, you don't get flustered by those complexes. We'll start with the first ECG sent by Dr. Praveen. A young male with no history of renal disease presents to the ER. Echo is normal, presents with this kind of an ECG. I presume the age being young is probably 30-35, and this is the ECG. Potassium was 7.5. So the question is, what should we do? Should we rush the patient to the cath lab, or what should we do? Potassium being 7.5. We can have a little bit of audience response if it is there, but nevertheless the most important question probably they are asking is whether to treat this as an acute coronary syndrome or treat it as hyperkalemia. Now between the two, what is going to kill the patient is hyperkalemia. It's important to remember, when hyperkalemia starts producing QRS widening and notching in the QRS, that is a sign just before asystole or VF. That is, you see a notching of QRS and QRS widening. It's not a mild hyperkalemia as far as the cell is concerned. It's very severe hyperkalemia. Along with that, you can see a marked peaking of the T wave and effacement of the ST segment. What is confusing the picture is the ST elevation in V1, V2 and an ST depression in inferior leads. So in fact, several years ago, Dr. Levine described this as a pseudo-infarct pattern. Pseudo-infarct pattern is well described in hyperkalemia due to several mechanisms. One of the mechanisms is a coronary spasm during acidosis, and you can have regional ischemia during severe acidosis and hyperkalemia. Everything will resolve if you first treat the high potassium. High potassium in the setting of a myocardial infarction is also carries a poor prognosis. Nevertheless, my first option would be you do a blood gas. Within seconds you are going to get the pH. You start treating this as hyperkalemia first, and as was said, this patient's potassium was 9.1 and steadily improved. You can see that they call this as a dialyzable current of injury. Dialyzable, that is, when you dialyze, this current of injury will resolve, and that's why it's called dialyzable current of injury, and it will completely resolve once you correct the hyperkalemia. This patient, after treating the hyperkalemia, it looks much better. And one of the things to resemble this kind of a thing is they can have concomitant coronary spasm. You should be aware of that. The next ECG was sent by Dr. Venugopal. This is a 47-year-old male, known diabetic and hypertensive, came to ER with chest pain and profuse sweating 30 to 45 minutes prior to arrival to ER. And this is the electrocardiogram. As you can see, the AVR, it's completely flat line for some reason. There is marked attenuation of voltages in precordial leads, lead 1, 2, 3. You find there is a left axis deviation. There is very poor R wave progression from V1 to V3. There is left atrial enlargement. So you see poor R wave progression V1 to V3. And low voltage complexes in precordial leads, tall T waves and you can find an ST depression in lateral precordial leads, V5, V6. And one of the interesting thing is I want to draw attention to this PVC. This was described several years ago, I think in late 60s or early 70s, where a PVC can unmask the diagnosis of a myocardial infarction. When you see a QR pattern, not a RBBB, QR in B1, it indicates that there is a septal area of a scar, and most probably this patient has a coronary disease. You can find that there is a Q wave in lead V1, V2, it goes up to V3. So clearly there is a old septal scar, and the old MI was unmasked by this PVC. I don't know whether it's Sodipolaris probably could describe this. And this patient most probably has a coronary artery disease, left ventricular hypertrophy, and the fact that the voltages are really attenuated here, I don't see a standardization artifact here. We should be a little careful before drawing conclusions, but if that is the case, then it may suggest a myocardial edema or heart failure at this acute stage. We'd be interested to know the clinical details, but this needs to be treated as an acute coronary syndrome. You need to repeat an ECG to find out whether there is an acute myocardial infarction after a couple of hours. And the telltale sign is this QR in V1 during a PVC, which unmasks the old myocardial infarction. This is sent by Aman, who had seen, Aman, you saw this patient on, so this patient came to casualty, diabetic hypertensive with rapid heart rate, shortness of breath and palpitation. And this patient was given a beta blocker and felt better, 66-year-old diabetic hypertensive, and feels much better after an IV dose of beta blocker. Would we discharge this patient with a rate control medicines and Novax, that is dabigatran or rivaroxaban, give IV amiodarone to convert it to sinus rhythm? You can see a varying RR interval. So this is diagnosis is atrial fibrillation, or would we just treat it as ACS, give antiplatelets and heparin, or start warfarin and beta blocker? Now this is a very interesting ECG. We have shown this before. When you see a disparity in the ST segment between V1 and V2, V1 showing an T wave that is upright with a significant ST depression in V2 and a tall R, a sudden increase in R wave voltage in V2, you should suspect a dorsal wall infarction, posterior wall infarction. In fact, this patient had a tight occlusion of, complete occlusion of circumflex. Please remember, the left atrium derives its blood supply by a recurrent atrial circumflex branch, and when that is occluded, patients can present as atrial fibrillation. And this is a diagnosis not to be missed, because you miss the opportunity to either thrombolize this patient or do a primary PCI. You can confirm the diagnosis by taking an ECG in V7, V9, V7, V8, V9. Approximately 7% of patients with acute myocardial infarction have an isolated posterior wall infarction. But as a part of inferior wall infarction, you see it in 50% of patients. Why is this relevant? Because they are generally associated with large myocardial infarction. Untreated, they develop severe ventricular dysfunction and more mechanical and electrical events. They develop significant MR. Most important is they derive the same degree of benefit from thrombolytic therapy or acute PCI. The problem is very often they get missed out, as this is one of the commonest cause of misdiagnosis of an acute MI is circumflex infarct. So what is it that is a clue? Is V1 showing an upright T wave with a sudden ST depression in V2 and a sudden tall R wave in V2 should make you suspect posterior wall infarction. Case 4, this is a 32-year-old lady who's a software professional who came with intermittent chest pain, seen by my colleague Dr. Vikram, who came with this kind of ECG. Would we treat it as normal? You'd like to exclude long QT, treat it as ACS or acute MI. In fact, we should congratulate Vikram for picking this up. When you have a very questionable ST elevation in inferior leads, you are not sure. This can be non-specific, this can be real. The most important thing here is to look at AVL. This was described by Skarlowski and Birnbaum. If ST is depressed in AVL in the presence of even minimal ST elevation in lead 3, it is suggestive of an acute inferior wall infarction. This patient had an acute occlusion of RCA. In fact, the history of smoking was not obvious. They went back and dug the history out later on, and she admitted to smoking 1 or 2 packs every day, and she underwent primary PCI with very good outcome. So the moral of the story is, when you are doubtful about an ST elevation in inferior leads, you need to concentrate on AVL. If it shows a sharp takeoff or an ST depression, you should consider that as an acute MI. This is an interesting patient who's a 60-year-old lady with a past history of CA colon, presented with chest pain and shortness of breath, had elevated tropi and hence was referred for further evaluation. Echo showed mild LV dysfunction, distal area of IVS was hypokinetic, coronary angiogram rightfully was done and it was found to be normal. So you have this ECG showing a sinus tachycardia, you have very small QRS complexes in precordial, standard limb leads, attenuation of voltages, significant ST elevation. If you look at what is peculiar about this ST elevation, the terminal portion of the QRS is widened, ST is elevated in V2, V3, this is mid precordial leads. So in the presence of normal coronary artery, when you have mid precordial ST elevation with sparing of V1, that is basal septum is spared, QT is upper limit of normal, you should suspect that this is very typical of a Takotsubo cardiomyopathy, stress cardiomyopathy. On going through the history, this patient recently lost her husband a week prior, and following that this has happened. Now why is this important? Because these patients have almost 20 to 30% chance of recurrence if you don't address the underlying problem. Second is, there's a high tendency for recurrence and 10 to 15% chance of thromboembolism. So these patients we may have to consider, when there's a large area of akinesia, you need to consider thromboprophylaxis with oral anticoagulation for a short period. This is an interesting patient, a doctor's mother, who presented a 72-year-old lady, diabetic, hypertensive, had a past history of coronary disease, had stenting recently of the RCA, was discharged on statins, clopidogrel, aspirin, metoprolol and metformin. She came with a history of palpitations to casualty and she was treated, and then they reassessed and called us saying that this patient had a recent stenting and she is on dual antiplatelets, but she has a atrial fibrillation. So should we add warfarin? Should we add dabigatran and reduce the aspirin to 75? Should we add apixaban BID and reduce aspirin to 75? Or consider the risk benefits and continue only antiplatelets? So this is the ECG lead 1, 2, 3. Please look at the ECG carefully. V1, V2, V3, V4 to V6. Now this is important because on the one hand you want to prevent a cerebrovascular accident due to a thrombus or an embolic complication. But all of us know when you give triple drug therapy, that is antiplatelets, dual antiplatelets plus oral anticoagulation, the risk of cerebral bleed significantly increases. Why is this relevant? Because we presume that everything that is irregular is atrial fibrillation. What is happening is, you can see sudden, there is QRS, QT, everything becomes squished up and then it becomes wider. The tape speed changes, and that's where it looks like there is an artifact. That's why it looks like varying RR interval. This is not atrial fibrillation. This patient was given a dose of IV adenosine, and this successfully it was ablated later on. All that she had was an AV nodal re-entry. Going back through the histories, a couple of years ago she has been having recurrent episodes of palpitation and presyncope, and we saved her because we go by guidelines thinking that diagnosis is easy, but most important for future physician is to make a proper assessment of clinical diagnosis and risk stratification. Classic example, if we had labeled this as AFib and given her triple therapy, we are unnecessarily submitting her for a risk of cerebral bleed. This is an interesting story of a gynecologist who was being practice recently slowed down her practice because of stiffness of the fingers, hands, everything because of rheumatoid arthritis. Was started on hydroxychloroquine 200 milligram once daily and non-steroidals, developed AFib, and then she started on amiodarone. And a week later she says, I am not feeling well, had a transient near syncope while climbing stairs. What do you think is the cause of her symptom? Do you think it's a supraventricular tachycardia, meaning recurrence of atrial fibrillation, or is it a VT, or because of the drug she has developed a AV block, transient paroxysmal AV block? Now with this COVID era, a lot of people are on this combination of hydroxychloroquine and azithromycin. Please remember, this is all you will see on the ECG. When you see the T wave varying in amplitude between beat to beat, it's called T wave alternance. This is a sign where the patient is likely to fibrillate any time. So ventricular fibrillation is a real risk in this patient, and a combination of hydroxychloroquine and amiodarone has done this. This can happen if you give a combination of azithromycin with hydroxychloroquine or amiodarone. Any of these drugs can cause, levofloxacin can cause this. So all that we did was we stopped both the drugs, repeated the ECG. A couple of days later everything became normal, and then she was restarted on hydroxychloroquine alone. She didn't require amiodarone for her prophylaxis. I think I'll stop with this, and let me just see. I think there are a couple of other questions. 10-year-old boy with from Fever Hospital has got this kind of ECG, has fever and rash patch. So what you can see is AV block, sinus tachycardia and AV block. This is very typical of myocarditis. If you see a patch in the throat and myocarditis, is diphtheria until proven otherwise. Most likely the diagnosis is diphtheritic myocarditis. You can also get tonsillar pharyngitis with rheumatic fever and myocarditis can happen. That's one of the differential, but most likely you are seeing a diphtheritic myocarditis. Classic findings of sinus tachycardia, P wave accelerates, but there is an AV block, marked T wave changes. Everything suggests that the child probably is suffering from an acute diphtheritic myocarditis. You need to start treating immediately, and there is a high tendency, mortality is high when they develop AV blocks and myocarditis. You need to be very, very aggressive in treating this. This was again sent by Dr. Praveen. 55-year-old male, diabetic, came with complaints of giddiness, diagnosed of sinus pause with bradycardia. Pacemaker was placed, set at rate of 70, post PPI. This is the ECG. So you can see a pace rhythm. This is in bipolar pacing. You will listen to more of this from Vikram. And when the rate accelerates, this is a demand pacemaker. So when the patient's intrinsic sinus rate becomes faster, the pacemaker doesn't fire. It allows the intrinsic rhythm to come up again periodically, and you can see a very prominent R wave which is due to a PVC coming from the left ventricle. So this patient we need more clinical details from this patient. One thing is, we will again go through, if the primary problem is with the sinus node, then it is better to pace the atrium rather than the ventricle, because then you will preserve the ventricular function over a period of time. I will probably leave my colleague Dr. Vikram to address these issues. And then the subsequent ECG again is a frequent bigeminy. You can see this suggests lead 1 is right to left. You can see a R wave in lead 1, which means it's coming from right ventricle most probably. 2-3 is upright, it's a right ventricular outflow PVC, and this is coming in a bigeminal pattern. So RV outflow PVC in a bigeminal pattern. The sinus ECG shows a significant ST depression in lateral leads, and you can see a very peaked P wave. So this patient has an additional myocardial disease. We need further evaluation, further information, but a very interesting ECG. Outflow tract PVC. You can see from V1 to V3 there is no poor R wave progression, again confirming it's coming from right ventricular outflow tract, and the coupling interval looks constant, and there is an ST depression in V1 to V4, suggestive of significant LVH here. You should rule out HCM, hypertrophic cardiomyopathy, LV hypertrophy due to hypertension, whatever be the several differential diagnoses. I think we'll stop with this, and here's some further thing. Concentric LVH, serum creatinine is normal, so this is some cause of LVH. It can be as common as an obstructive sleep apnea and hypertension which is causing this problem. There is data to suggest this subset of patients benefit from beta blocker and ACE inhibitor in preventing sudden cardiac death. There are JACC publications to attest to this effect. You can go and look it up. I'll stop with this and ask my colleague Dr. Vikram. Come Vikram, we'll get started with his presentation.
Good evening one and all. Today I will be talking about the basics of pacemaker ECG interpretation. So what are the 3 steps in the evaluation of a pacemaker function? First is the history, followed by an ECG and an imaging. Imaging consisting of chest X-ray and an echocardiogram, and if you are lucky and working in a place with CAT facilities, you can do a fluoroscopy. Coming to the history, the pacemaker malfunction can present with 3 different types of symptoms. One is syncope, breathlessness, and the third one is palpitation. What does a syncope indicates? A syncope usually indicates a pacemaker malfunction. Rarely it can be due to the intrinsic disease, and conditions like ventricular tachycardia can also produce syncope, but more commonly it is due to pacemaker malfunction. The patient can have breathlessness. The breathlessness in the pacemaker is usually due to 2 reasons. One, the pacing of the heart. As the time goes by, it will weaken the myocardium and produces what is called as pacing induced cardiomyopathy, leading to new onset LV dysfunction. This can cause breathlessness. Sometimes if you are putting a single chamber pacemaker, the single chamber pacemaker, what it does, if it is put in the ventricle, it will only pace the ventricle. So as a result there is no AV synchrony. So what happens is AV dyssynchrony. What is the meaning of that? AV dyssynchrony is the atrium and ventricle are not contracting in a coordinated manner. Both will contract independent of each other, and this can lead to breathlessness. The palpitations is usually caused by new onset of any arrhythmia like atrial fibrillation, or what is called as pacemaker mediated tachycardia, which is very rare occurrence. So in an ECG, what do we see? The first thing is rate. The essential function of a pacemaker is to pace at the set rate. It means it will not allow the heartbeat or the pulse rate to fall below the set rate, with few exceptions like hysteresis. So that is the first and foremost function of the pacemaker. Number 2, sensing and pacing function. That is what we have to evaluate. These are like eyes of the pacemaker. So what is the meaning of a sensing function? Sensing function is nothing but, sensing means to see. That is, pacemaker keeps on seeing the intrinsic activity of the heart, whether the P and QRS is formed, whether this occurs in a regular fashion or not. That is the function that we call as sensing function. What is the meaning of pacing? Pacing is nothing but to act. How does the pacemaker act? It gives a current or it fires up. So this small amount of current that goes into the myocardium causes depolarization. So the sense is to see. When the pacemaker doesn't see anything, it will prompt the pacemaker to fire. So these sensing and pacing function are very coordinated function that happens in the pacemaker. And the fourth function is to detect the arrhythmia, and it will tell us when we interrogate the device whether there is an arrhythmia or not. Very rarely you see the arrhythmias in ECGs. So the first step in a identification in seeing the pacemaker ECG is whether there is a pacing spike or not. There are two modalities of pacing in a given pacemaker, what we call as unipolar pacing and bipolar pacing. Modern day pacemakers are usually bipolar pacing. So how do we differentiate? A unipolar pacing, it will have a very large stimulus artifact. If you look at from the distance itself, you will be able to say this is a pacing, and the Qrs complexes is produced because of the pacing, because you essentially see a very large stim artifact, that is stimulus artifact. But in modern day pacemakers, what you see is, you see a very small artifact. That too, if you see in this specific ECG, you do not see any artifact in lead 2, AVL or V2, but if you look in lead V4 and V5, you see a small artifact. But essentially, all these broad complexes are produced by this pacemaker stimulus. So it is very important to look the ECG carefully for the unipolar pacing or bipolar pacing. So this is another ECG. This is in the modern day ECG machines. Instead of seeing before the P or a QRS complex, if you look at the top of the ECG, you see this vertical lines. This also indicates pacing. If you are not able to see in a native in the QRS rhythm, you can, if you look at the top of the ECG, this may also give a clue whether this is a pacemaker mediated QRS complexes or not. So how do we identify the given stimulus is capturing the ventricle or not? So here we will look at this diagram. So you see a pacing stimulus and you see a pacing stimulus. Subsequently, you do not see any pacing stimulus in beat 3 and beat 4. What has happened here? So in the first complex, after a pacing stimulus, a QRS has come. And this QRS you see is essentially a very broad QRS compared to the subsequent 3 beats. Why so? In a normal heart, the entire depolarization of the ventricle is caused by the His-Purkinje system, which is so fast and it occurs simultaneously. But in case of pacemaker, so this is a pacemaker lead which has been implanted in the right ventricle. After the pacemaker gives a current here, So the impulses spread in this fashion from muscle to muscle to muscle to muscle. So it takes a very long time to reach the entire ventricular walls. So the QRS complex in this paced ECG that we call as captured beat is essentially a bigger one. What is the difference between beat 1 and beat 2? In beat 2 what you see, again you see a stimulus, but this is relatively narrower compared to the first beat. What has happened here? Here the pacemaker has also given a stimulus, and at the same time the intrinsic heartbeat has also come at the same time. So the both has competed with each other, and one half of it, the depolarization of the heart, has happened due to the pacemaker, and the other half has happened due to the His-Purkinje system. So this is an intermediate complex. Intermediate to what? Intermediate between the beat 1, which is fully captured beat, and the third beat, which I call it as intrinsic beat. Why this is an intrinsic beat? You see there is no pacing stimulus, and the beat is relatively narrow when compared to the first two beats. So this is an intrinsic beat due to the native His-Purkinje conduction. If you ask me why the first two beats are paced by the pacemakers, but here there is no pacing stimulus, has the pacemaker malfunctioned? If you ask me, the answer is no. Why? Because the pacemaker, as I said, it will not allow the heart to pace below a certain rate. So if no impulses had come at this point, the pacemaker would have probably paced at the end of this red line. But what has happened here is an intrinsic beat has come here, and this intrinsic beat has been seen by the pacemaker, that is, it has sensed it. So it has stopped the pacemaker from giving an unnecessary pacing spike. So that is why this beat is a natively conducted beat, and so on and so forth. Again, the intrinsic beat has come before the period ends, and subsequently, as there is no intrinsic beat in this long interval, the pacemaker has not seen any intrinsic, that is, has not sensed any intrinsic beat, and it has given a pacing stimulus and depolarization. So this is what we have to see in an ECG, that is capture, fusion and intrinsic beat, and how it occurs. So next is the identification of the pacing site and what mode the pacemaker has been set. There are two types of pacemakers that we usually implant. It can be a single chamber pacemaker or a dual chamber pacemaker. A single chamber pacemaker can be implanted only in the atrium or only in the ventricle. In the dual chamber pacemaker, we implant in the right atrium and the right ventricle. So what do we see in this ECG? So this ECG, as you see a broad QRS complex, and you see two spikes. So there is a first spike. After a first spike, what you see is a P wave, and after the P wave, the pacemaker has decided to give another spike. So what has happened here? Since there is no formation of the P wave on its own, the pacemaker has given a spike, and this spike has captured the atrium and it has formed a P wave, and it has set what is called as AV delay. So after every atrial spike, the pacemaker will wait for certain period that can be set by the physician, that we call it as AV delay. So if within that AV delay, if the pacemaker doesn't see any intrinsic ventricular event, then it will prompt the right ventricular lead to give a current. So that is what we see here as a spike, and following that, what has happened here is a captured beat, that is a broad QRS complex which is produced by the pacing. So this is a dual chamber pacemaker. So essentially this is an atrial pace and ventricular pace. So both of these things has happened in this ECG. So how this ECG is different from the previous ECG? So if you look at this ECG, there is only one pacing spike, and the pacing spike is before the P wave. And what do you see here? You do not see any pacing spike, and this QRS is relatively narrow. So what has happened here? So since the pacemaker has not seen any intrinsic P wave, it has decided to give a pacing stimulus, and following that a P wave has been formed. And how this P wave has conducted to the ventricle? It has conducted as it usually conducts normally. Through the AV node it has gone, and the His-Purkinje system has caused the depolarization of the ventricle, producing a Qrs complex. As the pacemaker has seen this Qrs complex, it has stopped the pacemaker from giving a pacing stimulus. So this is an A pace which has produced the depolarization of the atrium, producing the P wave, which has normally conducted through the AV node and caused the depolarization of the ventricle. So when we talk about the pacemaker, we always talk about various modes of the pacemaker, the AOO, AAI, or it starts with D. So what does these stands for? So usually it is a 3-letter or a 4-letter coding. So the first letter usually indicates the chamber that is paced. If it is A, that means atrium. If the V comes here, it means ventricle. If the letter D comes, it means dual. That means both atrium and ventricle. So that is what the first letter stands for. That is the chamber which we have chosen for pacing. What does the second letter stands for? The second letter, for example, you see here AAI. So the second letter here stands for the chamber that is sensed. So what does this means is, so here the lead is in the atrium, so it will pace the atrium. The lead is in again its atrium, so it will sense. So essentially it will pace and sense the atrial impulses. So what does this mean? AOO and AAI. O means it is neither performing the action of that. So here the second letter, as I said, it stands for sensing. When the O is replaced, it doesn't perform the function of sensing. So in this pacemaker, when it is in AOO mode, this pacemaker will essentially do only one function, that is pacing function. So what do we see here in the first strip? So without seeing any intrinsic activity of the atrium, it keeps on giving the pacemaker stimulus. So first it has given a pacemaker stimulus and it has formed P. So again the same thing has happened. But what you see here is a native P, which is a narrow normal P, which is produced by the sinus impulse, has come. But what has happened here, because the second letter is O, the second letter stands for sensing, and the O says that it is not doing its function. So in spite of the P wave that has come, the pacemaker has failed to recognize this P wave and it has given a pacing spike. And why this pacing spike has not captured in spite of giving a current? Because the atrium has already depolarized here and this pacing current has fallen in the refractory period. You know, whenever we give a stimulus in the refractory period, it won't elicit a response. So that is what has happened here. So this is essentially an AOO pacemaker which only performs a pacing function. So coming to the lower panel, AAI. So as I said, first A stands for pacing and second A stands for sensing. So that means this pacemaker does both the activity it is supposed to do. So again there is a pacing spike because it has not seen any intrinsic P wave and it has depolarized. Again the same thing has happened, but when you compare the third beat of the upper panel and the third beat of the lower panel, what has happened here? So here the pacemaker has seen the P wave, so it has not given any pacing stimulus. Contrary to this first upper panel where it has given a stimulus because it has not seen. So here it has seen and it has not given, that is it has inhibited the pacemaker from giving the stimulus. This I stands for inhibition. So the same thing we can explain with dual chamber pacemaker also. So coming to the important part, how to identify the sensing and pacing malfunction. So let us see this ECG strip. So what do you see here? You see a P and a QRS. So here you do not see any pacing spike. Agreed? Yes. So how does the subsequent QRS complexes look? The subsequent QRS complex looks identical to the normal sinus rhythm. What else do you see in this ECG? You see a pacing spike. You see a pacing spike here. You see a pacing spike here. You see a pacing spike here. So what has happened here? Should the pacing spike come here at all? No, the pacing spike should not come here because the reason being the QRS is normally produced by the heart's own sinus node which is conducting to the ventricle. So the reason this has been produced, the spike being produced, is the pacemaker, in spite of the pacemaker, what the abnormality here is, though there is a normal QRS complex, the pacemaker has essentially failed in its function. So what is the function it has failed? It has failed to see. So when the pacemaker failed to see the intrinsically conducted P or a QRS, we call it as failure to sense. So here the chamber that has been undersensed is ventricular chamber. Coming to this ECG. So what you see in this ECG, you see a P and a QRS and a P and a QRS, but you see a pacing spike after a P. So this is an atrial based pacemaker. So what has happened here? Normally a P wave has come. If the pacemaker has properly sensed this P wave, there's no job for the pacemaker to give a pacing spike here. Since the pacemaker has not sensed this P wave, it has thought that there is no intrinsic atrial activity, so it has decided to give a pacing spike on its own. So this is a failure to sense the atrial signal. So it can occur in both the chambers. So what is failure to capture? So how is it different from the previous ECGs? So here what you see is the pacemaker has given, you see so much of stimulus artifact, but you count the number of QRSs. The QRSs are far less than the number of stimuli that is given. So what has happened here, the pacemaker has given a current here, but it is not able to produce any depolarization leading to any meaningful QRS. So this is called as failure to capture. Failure to capture is one of the very serious complications of the pacemaker, because the patient will be essentially in brady, and even if this has not captured, it will lead to asystole, and it can lead to syncope or sudden cardiac death due to pacemaker malfunction. So applying the same logic here, what has happened here? So you see a QRS complexes, you see 6 QRS complexes, but you see how many P waves? Let's count. So for the first beat you see a P wave, for a second beat you see a P wave, but the next 2 beats you do not see any P wave. So what has happened here? But what you see is there are 2 pacing spike for each P QRS complexes. So after giving an atrial spike, a good P has formed. The pacemaker has waited for some time, that is the AV delay that we have set. As there is no intrinsic QRS complexes, the ventricular channel has decided to fire, and it has captured also very well, and there is a formation of a good QRS complex. The same thing has happened in the second beat also. But what has happened in the same beat, the atrium has given a pacing stimulus, but there is no formation of the P wave. So this is failure to capture the atrium, and this can also lead to some kind of an AV dysynchrony. So what really has happened here? If you see, there is a failure to capture the atrium here. So the atrium has really not depolarized at this point, but the ventricular spike given by the ventricular channel has depolarized the ventricle, producing a QRS complex. Since the atrium is very prime and it is not in any refractory period, this QRS complex has traveled retrogradely through the AV node, and this has depolarized the atrium. So if this keeps on happening, so what you essentially get is the atrium contracting after a ventricle. This is what I call as dyssynchrony, and this can lead to symptoms like palpitation, more importantly breathlessness. So this is a very tricky ECG. So what is the malfunction here. So let us analyze. If you recall my initial few slides, I told that in order to see the pacemaker spikes, you have to see carefully, because modern day ECG filtering and bipolar settings in a pacemaker gives a very small spike. You will not be able to see, and if you look very superficially, you may miss the pacemaker spike also. But if you look at this ECG itself, it says there is a long pauses without any QRS complex, and the pacemaker which is implanted in this patient is essentially not performing its activity. So let us take this rhythm strip. So let's concentrate here. There is a P wave and there is a QRS complex. So how does this QRS complex is produced? If you look at the simultaneous beat above, there is a pacing spike. So this is essentially a paced QRS complex. And again a P wave has come on its own, that is an intrinsic P wave. And is there a pacing spike here? You don't see a pacing spike here, but if you look at the beats above that, the pacemaker has certainly given a pacing spike, but you do not see any QRS complex. So this is failure to capture. Again, I would like to say this is a very serious complication, and this can lead to syncope. So to illustrate how our pacemaker malfunctions can present in varied way, I'll show this case to you. So this is a 67-year-old male who presented elsewhere with recurrent episodes of syncope. His past history was significant for a complete heart block, for which he has undergone a pacemaker, and the pacemaker, as I said, the letter D indicates dual function. So the first is triple D, that is the leads are both in atrium and ventricle, and it functions both pacing and sensing function. So this is the background of this patient. So this was the presentation ECG of this patient. So what do we see in this patient? So we see a P wave, we see a QRS complex. Essentially this pattern repeats itself. So does this explain patient syncope? If you ask me, it doesn't, because the pacemaker is performing its function very well. You see a P wave and you see a large pacing spike, and it has essentially captured ventricle, producing the normal QRS complex. So for everyone, this is a normal pacing function of the pacemaker. So having seen this ECG in the beginning, the pacemaker, the patient has been referred to neurology department for workup of syncope. So they have done lot of investigations, and finally the patient underwent 4-vessel angiogram, that is carotid and vertebral angiogram, and there they found a hypoplastic left vertebral artery with some atheromas in the carotid bulb. So with this background, the treating team decided to conclude that this is a case of a cervical spondylosis because of some degenerative changes in the X-ray, and subclavian steal syndrome because of the findings of the 4-vessel angiogram. So the patient was advised restriction of the neck movement, a cervical collar was given. Nevertheless, the patient continued to have recurrent syncope as high as 4 to 5 episodes per day. As the patient's symptom was not relieved, we further decided to evaluate the patient. So when the patient came to us, the patient had a very peculiar symptom. The symptom was that whenever he moves his left hand, he goes into syncope. So what is really happening in this patient? Like cardiac muscle, skeletal muscle also has action potential, and that also produces some electrical signals. So how is it related to this ECG? So what has happened in this patient is, this patient's pacemaker leads has fractured. So whenever this patient moves his hands, so the pacemaker fractured leads, instead of sensing the native QRS complexes of the ventricle, it has picked up the signals from the muscle. A pacemaker doesn't know to differentiate whether this is QRS complexes is due to cardiac or extra cardiac. So the pacemaker, what it has decided after sensing an abnormal signal, it has decided to withhold the pacing stimulus. So that is why you see a huge pause here. You see a P wave and the pacemaker has seen some abnormal impulses from the leads. So it has decided not to pace. So this has led to syncope in this patient. So this function of sensing of the pacemaker, other than the native cardiac impulse, we call it as oversensing. Again, like failure to capture, oversensing can lead to death or recurrent syncope leading to trauma. So this is very important to identify it. So this is one of the patient's ECG. As I said, the pacemaker, when we put a single chamber pacemaker, it will cause AV dyssynchrony in a case of complete heart block. So this patient had breathlessness after the pacemaker has been placed. What is the reason? So is the pacemaker causing the breathlessness, or intrinsically that any other disease in this patient causing breathlessness? If you look at carefully, the QRS complexes are very wide and you see a small or a tiny pacing pulses before every QRS complex. So the pacemaker is essentially performing the capture function very well and also sensing function very well, because you don't see any pauses or anything. But what has happened here, after capturing the ventricle, as I said earlier, this impulse has gone retrogradely and captured the atrium. So it is ventricle capturing, getting activated first, followed by the atrium. So this is a kind of dyssynchrony which has led to this symptom of breathlessness in this patient. So some other aspects I would like to highlight in a patient. We call it as EOS or EOL or a ERI. What does this mean? Usually the pacemaker malfunction, if any patient comes to you, what you have to see, just see when the pacemaker was implanted in the pacemaker. Suppose if it was implanted many years ago, like 8 years ago, 10 years ago, it is good reason for you to suspect what we call as end of life or end of service. That means the battery of the pacemaker has drained so much so it has started malfunctioning. Sometimes we call this ERA, that is called as elective replacement indicator. That means you have another 3 months before you electively take up the patient for the battery replacement. And one of the common reasons a physician might be called in peripheral centers is to give opinion for a patient who is going to undergo surgery, who also has a pacemaker. So what do you do and how do you manage? Having you confirmed that the pacemaker is not a very old pacemaker, that means the recently implanted pacemaker, or it's only 4 or 5 years after this, what you should do, you should use the magnet. And why? So this is a pacemaker ECG in a patient who has undergone a surgery. You see a normal QRS complex, suddenly you see what do you call as a lot of noise. What do we call as? We call this as noise or some artifacts. So this is definitely not a native QRS complex. So what is this? You know, in almost every surgery they use cautery, and this cautery also produces electrical signals. So these electrical signals will be picked up by the pacemaker. So it will consider this as a QRS complex. So what this pacemaker is happening to this pacemaker is it is oversensing these non-physiological signals due to the electrical signals of the cautery, and it has stopped its pacing function. So this will lead to syncope and whatnot in a surgical theater. So how do we tackle this? So a very simple way to tackle this problem is to place a magnet over the pacemaker battery. So what happens when we keep a magnet over the pacemaker battery? We literally close the eyes of the pacemaker. That is, we are literally stopping the sensing function of the pacemaker by keeping a magnet strapped over the pacemaker battery. So what is the only remaining function of the pacemaker? it is to pace. So the pacemaker will not see any intrinsic complexes, but it will keep on giving a regular spike at the set rate, causing depolarization of the ventricle. So whenever you are asked for an opinion, if the patient is, for example, is going to go for an emergency surgery, so the easy way to troubleshoot when you don't have any the pacemaker technician or any cardiologist around is to place the magnet over the pacemaker and strap it, so that the pacemaker goes into asynchronous mode and it won't see any noises produced by the cautery. So there are few points I would like to say regarding the pacemaker and choosing the mode. So usually in a sick sinus syndrome, what is abnormal is the sinus node. So you can, in the most of the scenarios, you can get away by placing a single chamber pacemaker. The single chamber pacemaker is usually an atrial based pacemaker. As the AV node is usually normal, it will normally get conducted through the AV node into the His-Purkinje system, causing a normal QRS complex. One point that you have to remember is, even in a patient with sick sinus syndrome, there is a chance of, very minimal chance of these patients going for complete AV block. So you have to know this risk when you give a atrial based pacemaker in a sick sinus syndrome. So if it is an AV block, what I expect from the pacemaker is to undergo a sequential pacing, that is synchronous pacing. The synchrony can only be achieved when you have two leads, one lead in the atrium and one lead in the ventricle. So for any patient with an AV block or a complete heart block, we expect the patient to undergo dual chamber pacemaker. There are exceptions to it. So one more point I would like to impress upon is LV dysfunction. So as I said earlier, when we pace the heart, the impulses get conducted from muscle to muscle. When this happens chronically in a ventricle, the ventricle undergoes some form of a change. A very weak muscle will eventually, the muscles will become weak, and it will lead to pacemaker induced, that is pacing induced LV dysfunction. Why this is happening? Because pacing the ventricle will cause a, right ventricle will cause a left bundle branch block. You know, whenever there is a left bundle branch block, the heart is not contracting in a synchronous manner, and it is contracting in a dysynchronous manner. That is, septum will contract at one time, left ventricular lateral wall will contract at one time. So when this happens, there is no uniform pumping action, and finally it will lead to what is called as pacing induced LV dysfunction. How do we overcome this? So nowadays in our institute and in many of the institutes in India, we have moved from what is the conventional pacing from the right ventricular apex to what is called as physiological pacing. So what is a physiological pacing? In conventional pacing, we screw or keep the lead of the RV in the RV apex or in the RV septum. Essentially, you screw it in the muscle, and what you get is a very wide QRS complex as depicted here. What is physiological pacing? Instead of screwing here, you directly place the pacing lead into the His bundle or into the left bundle. So you mimic the normal conduction of the His-Purkinje system. So this will essentially lead to a narrow QRS complex and a synchronous contraction. So when you produce a synchronous contraction in the ventricle, the incidence of the pacemaker induced LV dysfunction will naturally come down. So I'll show you, initially I showed the ECGs of the RV pacing where you saw a very wide QRS complex. This is one of the case where we have screwed the lead in the His bundle. If you don't look carefully enough, you will consider this to be normal, except for the pacing spike you see here. So this we have screwed it in the His bundle. After P wave, the pacemaker has given a spike and it has produced a very narrow QRS complex, very much like an intrinsic beat. So the very advantage of this kind of pacing is there is no dysynchrony and the QRS complex is quite narrow. This is an example for His bundle pacing, and there is another modality of the pacing that we have recently adopted. We have we are performing this now, though this is called as left bundle pacing. How do we pace? So we screw the right ventricular lead little deep into the septum to capture the left bundle. Left bundle is also the physiological conduction system, and here also you get a very narrow QRS complex. The difference between the previous ECG and this ECG is you see a kind of a narrow complex with a right bundle branch block. So finally, this question is often asked, can a DC shock if there is a VT in a pacemaker patient? The answer is yes, you can give a shock even if the patient is having a pacemaker. And this is my final slide. So this is a 50-year-old male implanted a triple DR pacemaker. What is the problem? So if you ask me what is the problem, there is no problem here. Reason being, you might ask, we have put a pacemaker, where are the pacing spikes? As I said earlier, the pacemaker will step in only when there is no native or a P wave or a native QRS complex. When the heartbeat is above the average set rate and it is produced by the intrinsic conduction system, there is no work for the pacemaker in this patient. It will just keep watching. Thank you.
Thank you, Vikram. That is a very exhaustive review, and like always, I would welcome all the delegates to post any questions if you have, and we'll be happy to pick them up and send it to you back as answers. In the interest of time, I would like to close this session by thanking all of you for patiently attending this webinar, and I would like to thank